Respiratory physiology. The last time I was here, we were talking about respiratory mechanics, and we did not get through all of the material that I planned to talk about that day. We had talked a little bit about respiratory system compliance, had not talked about resistance, so we'll finish up compliance a bit today, talk about airways resistance, and then we'll talk a little bit about how we can make some of these measurements in our mechanically ventilated patients. So this is the scheme that we have been going through. So starting actually about a year ago, I guess, we talked about ventilation, diffusion, blood flow, gas exchange, blood gas transport, and acid base. Now we are talking about respiratory mechanics, and later this summer or this fall, we'll talk about controlled breathing. And then we'll talk about what we'll do after that. Maybe we'll go back and start at the beginning again. Or maybe Bob will have ideas for other things.
I'll come up with a list for you.
So today we're going to talk a little bit about the normal pressure-volume relationships of the lungs, chest wall, and respiratory system, which is kind of where we stopped the last time. Then we'll talk about laminar and turbulent flow, which gets into a discussion of airways resistance. We'll describe the effects of the equal pressure point and why it is that if you blow out harder, the gas doesn't come out of your lungs necessarily any faster. Talk a little bit about time constants to explain the distribution, the gas flow in the lungs, and then apply respiratory mechanics physiology to mechanical ventilation. So this was the last figure that we had looked at last month, which describes the compliance of the chest wall here, the lungs here, and then the lungs and the chest wall together. And we had pointed out that if we take the chest wall and we remove the lungs, and we just place the chest wall on the table and measure the pressure inside the chest wall at various volumes, the pressure throughout most of the lung volume, except at very high lung volumes, is negative, because the tendency of the chest wall is to expand outward. So if you took me and you strip my lungs out of my chest wall would go out like this. The lungs have a tendency to collapse. So over most of the lung volume, the pressure in the lungs is positive. So if you took my lungs out of my chest wall, put them on the table, measured the pressure inside the lungs, it would be a positive pressure because the lungs are trying to collapse inward. So the outward expansion of the chest wall is opposed by the inward collapse of the lungs, so that if we put the lungs and the chest wall together at a normal resting volume, functional residual capacity, the airway pressure is 0, but the pressure in the pleural space is negative because the lungs are going this way and the chest wall is going outward. Also notice that the pressure-volume relationship of the lungs and the chest wall together is kind of sigmoid. It's sigmoidal. It's S-shaped. So that there is curvature at low volumes, there's curvature at high volumes. Throughout most of the lung volume, the relationship is relatively linear. And you can also see that the curvature at the bottom of the lung-chest wall relationship is primarily the result of the chest wall elastance or compliance, and the curvature at high lung volumes for the lung and chest wall together is primarily the result of the elastance or the compliance of the lung. So then, points that we just made is that the isolated chest wall expands outward, except at very high lung volumes. The isolated lung collapses inward, and that's because of the elastic properties of the lungs and the chest wall. At alveolar pressure, at FRC, at normal resting volume, the alveolar pressure is 0 and the pleural pressure is negative. So there's no such thing as physiologic peak. because normally at end exhalation, the pressure in our alveoli is 0. Lots of good reasons that we apply PEEP in mechanically ventilated patients, but it's not because it's physiologic. The normal compliance, the normal volume-pressure relationship, the slope of this relationship, the normal compliance of the lungs is about 0.2 or 0.2 liters or 200 milliliters per centimeter of water. The normal compliance of the chest wall is also about 0.2 liters per centimeter of water or 200 milliliters per centimeter of water. But if we put them both together, the compliance of the respiratory system, which is this line, is the normal compliance is about 0.1 or 100 milliliters, 0.1 liters per centimeter of water. And the reason why the compliance of the respiratory system is less than the compliance of the lungs or the chest wall by itself is because they are moving in opposite directions. And mathematically, the relationship is that the elastance of the respiratory system is equal to the elastance of the lungs plus the elastance of the chest wall. The elastance is the inverse of compliance. So 1 over the compliance of the respiratory system is equal to 1 over the compliance of the lungs plus 1 over the compliance of the chest wall. And you can plug in the numbers yourself. 1 over 0.2 plus 1 over 0.2 is 0.1. So the compliance of the respiratory system, the lungs and the chest wall together, is half of the compliance of either one by itself. And the other thing that I'll point out here again is that the normal shape of the volume-pressure relationship, the normal shape of the pressure-volume curve, is determined by the elastance of the chest wall and the elastance of the lungs. And that's different than what we see clinically in mechanically ventilated patients with ARDS, where the shape of this curve has a lot to do with recruitment of lung rather than elastance by itself. So this illustrates that point. So here is the volume-pressure relationship, or the pressure-volume curve, normally beginning at functional residual capacity, because as I had pointed out, above functional residual capacity, the relationship is relatively linear, except at high volumes. This is what the pressure-volume curve might look like in patients with ARDS, where there is a lower inflection point where the curvature changes, and there is an upper inflection point where the curvature changes. In the normal pressure-volume relationship, this shape is determined primarily by elastance, the elastance of the lungs and the elastance of the chest wall. Whereas in a mechanically ventilated patient with ARDS, the shape of this curve is determined not only by elastance, but to a large extent by alveolar recruitment. And the lower inflection point is thought to be the point at which significant alveolar recruitment occurs, but recruitment actually occurs the whole way along the increase in volume along the pressure-volume curve. And the upper inflection point is thought to represent the end of alveolar recruitment and the beginning of alveolar overdistension. And years ago, back here at the MGH 20 years ago, there was a lot of enthusiasm about using the pressure-volume curve in patients with ARDS to set the ventilator. So the idea is that if we set the peak a little bit higher than the lower inflection point, we could prevent a lot of alveolar de-recruitment. And if we kept the plateau pressure and the tidal volume below the upper inflection point, we could avoid overdistension. And we used to measure pressure-volume curves in the ICU back when Bigelow 9 was the MICU many years ago, and use that to set the ventilator. And Bob has actually published some papers on that as well. Now there are some issues with using the pressure-volume curve to set the ventilator. So it requires sedation and often paralysis so that the patient is being passively ventilated. It is difficult to identify the inflection points. And years ago, probably more than 15 years ago, Scott Harris and Jose Venegas and I published a paper where we talked about mathematical curve fitting of this so we could determine more precisely the inflection points. It's difficult to isolate the lung versus the chest wall effects. So in patients with issues with chest wall elastance, such as obese patients, this loses some of its meaning. And the deflation limb of the pressure volume curve might be more important than the inflation limb, because often we're interested in when the lung de-recruits rather than when we reopen it. So there are a number of ways that clinically the pressure volume curve might be determined in a mechanically ventilated patient. This is actually what we used to do years ago in the ICUs, where we had a big syringe. Were you around for any of this, Ernie? This even predates
I was around.
Some of you were around. So we had a big 2-liter syringe, and we would go to the bedside. We would attach that syringe to the patient with a pressure manometer, and we would push in 100 milliliters of air and write down the pressure, and another 100 milliliters of air and write down the pressure. And then we would plot out the pressure volume curve like this and try to identify the lower and the upper inflection points. And that would always be, would bring about some chuckles from people who have not seen it before, to have this big syringe attached to the patient's endotracheal tube. Now, some of you may say, well, the ventilator, we can put up pressure volume curve on the display on the ventilator, so why don't we just do that? We could do that in any mechanically ventilated patient. And the problem with that is that the shape of the pressure volume curve is determined by a large extent in mechanically ventilated patients on the mode of ventilation. So this was actually done by me on this table many years ago with a ventilator attached to a test lung, and the only thing that I changed on the ventilator was from pressure control to volume control. And it looks like on pressure control that there is a lower inflection point, because that's how the ventilator delivers flow during pressure control ventilation. It tries to hit the pressure quickly at the beginning of the breath. Whereas if the only thing that's changed on the ventilator, on a test lung, where there should be no recruitment and de-recruitment, is if you go to volume control, it does not look like there is any upper and lower inflection points. So the pressure volume curve that we can display on any modern ventilator has very little meaning unless the patient's on volume control ventilation. That might not even have that much meaning there. If the patient's on pressure control or pressure support, you cannot use the information. Also, if the patient is actively breathing, is triggering the ventilator and so forth, then the shape of this curve will be more a matter of how much effort the patient's generating than flow from the ventilator. All that said, there are some ventilators, and I believe, maybe you know, Bob, I think the Hamilton ventilator is the only one that does this.
Well, I think that I'm told the Servo U also does it.
Oh, okay. So there are now...
The Hamilton for sure does it.
Yeah, so there are a couple of ventilators on the market that will do the pressure volume curve correctly, because they inflate the lungs at a very slow, constant flow. Very similar to what happens if you attach a syringe at the airway and make step changes in volume. And this is just an illustration from a paper published in Respiratory Care a few years ago of what that inflation and deflation limb might look like on a ventilator that has a PV curve function to correctly display the pressure volume curve. But no ventilators at the MGH do this. And I should point out as well that the use of the PV curve is controversial anyway as far as us setting the ventilator. Okay, now let's change our discussion for a few minutes to that of airways resistance. And as you know, the flow through a tube and the flow through an airway can either be laminar flow, as is illustrated here, or turbulent flow, as is illustrated here. And the big difference between laminar and turbulent flow is that laminar flow is much more energy efficient. So it takes more energy, more pressure to provide turbulent flow than it does for laminar flow. So ideally then, we would want flow to be laminar because it requires less energy to provide this flow. So how do we know then if flow is laminar or turbulent? So what determines whether flow through an airway will be laminar or turbulent? So this is determined by something like the Reynolds number. This is determined by the Reynolds number. And if the Reynolds number is a small number, so if this is a small number, that means the flow is laminar. If this number is a high number, it means the flow is turbulent. So the Reynolds number then determines whether flow will be laminar or turbulent. So in the numerator of this relationship is V, which is velocity. So it's not flow or volume, it's the velocity at which the gas moves. R is the radius of the tube, or the airway. Rho is density of the gas, and mu is viscosity of the gas. So it turns out that in the small airways of your lungs, gas flow is laminar because in small airways, the velocity at which gas goes through the airway is very low. And the reason why velocity through small airways is very low is that by the time the gas flow makes it past your trachea into the branching airways of the lungs, in the small airways, that flow is divided among millions of airways. So since there are so many small airways, the velocity of the flow through an individual airway is very small, so that in small airways, gas flow is laminar. And in large airways, like your trachea and your larynx and your upper airway, where the forward velocity is very high, the gas flow is turbulent, even though the radius is also high. So then these relationships determine the amount of pressure or the amount of energy or the amount of work for turbulent versus laminar flow. And the important thing, couple important things here are that, first of all, the amount of pressure for turbulent flow is going to be greater than it is for laminar flow because we have flow squared here versus flow not squared here, flow to the exponent of 1 here, to the power of 1. Also, you can see that radius is a big determinant of of the amount of pressure required for laminar versus turbulent flow. And the effective radius is much greater for turbulent flow than it is for laminar flow. But we can affect, for either turbulent or laminar flow, we can affect the amount of pressure or the amount of energy required by flow by changing the radius of the airway. So if we get secretions in the airway, the radius goes down and the amount of pressure required goes up. If we get bronchospasm, the radius goes down and the amount of pressure needed to produce flow increases. It's harder to breathe. If we administer a bronchodilator and we increase the radius of the airway, the amount of pressure or the amount of energy required to breathe will go down. And the effect of radius is very important because the effect of radius is very important because it's radius to the 5th or radius to the 4th power. This relationship also points out that in small airways where gas flow is laminar, as we said from the previous slide, the flow is density independent. So for laminar flow, small airways, flow is determined by the viscosity of the gas. For large airways where gas flow is turbulent, the flow is determined by the density of the gas. So if we think about then changing gas density, decreasing gas density, such as heliox, this will be potentially beneficial for large airway obstruction, like Stryer, will not be so helpful for small airways disease, like COPD, because with small airways, gas flow is laminar and density is not in the equation. So that's why we don't haul out the heliox tanks for a COPD exacerbation, but we might haul out the heliox tank for a patient with Stryer. And in a patient with asthma, it's actually a whole other lecture, but it's a little bit unclear as to whether heliox has a role there or not. Now, if we look at gas flow in and out of the lungs, as is illustrated here, you can see that each time you breathe in, about 400 to 500 milliliters of gas goes into your lungs. Tidal volume about 6 or 7 mLs per kilo. So when we think about ventilating patients with ARDS at a tidal volume of 6 mLs per kilo, we're ventilating them at a normal tidal volume, not at a low tidal volume. To create that change in volume, the intrapleural pressure drops by a few centimeters of water. So normally we only need to drop our intrapleural pressure by 2 or 3 centimeters of water to bring the tidal volume into the lungs. However, if the radius of the airway decreases, it will require more pressure and so forth, as we just talked about. Normally, the flow into the lungs and out of the lungs is sinusoidal. So if you think about it, how we ventilate patients, when we intubate them and we place them on the ventilator, we don't put them on a physiologic flow profile, because normally, physiologically, how we breathe is the flow is sinusoidal into and out of the lungs. And normally, for you and me, the peak inspiratory flow is about ½ liter per second, or 30 liters per minute. And the peak expiratory flow is about ½ liter per second, or 30 liters per minute. And the alveolar pressure is 0 during resting conditions, and it drops by 1 or 2 centimeters of water during inhalation, and increases by 1 or 2 centimeters of water during exhalation. So the alveolar pressure really doesn't change very much, a centimeter of water or so throughout the respiratory cycle, normally. This is you and me normally. Now, in a patient with stiff lungs or stiff chest wall or high airway resistance, it will require more of a pleural pressure change. The flows may be greater if the patient's in respiratory distress, and the alveolar pressure changes will be greater. So where is most of the resistance to breathing in your lungs? So most of the resistance to breathing in the lungs is in the central airway. So this is airway generation 0 being trachea. Out here at 20, actually even past 20, is where the alveolus is. So most of the resistance, the highest resistance to breathing for you and me, is in the central airways. The resistance to breathing is very low in the smaller airways in the lungs. And the reason for that is that there are millions of small airways. So there's only one trachea, obviously, as you know. There's only one trachea, and all the flow goes through that single airway. But by the time we get to the terminal bronchioles in the lungs, that flow is divided among millions of airways, so that the total cross-sectional area of the trachea is this, but the total cross-sectional area of the small airways is more than this. So the total resistance in the small airways is lower than the central airways. Now that can change with disease, such as in patients with COPD, for example. Also, it is interesting to note the effect of lung volume on airways resistance. So airways resistance, as you can see here, is low at high lung volumes, and airways resistance is higher at lower lung volumes. So there is this curvilinear relationship between airways resistance and lung volume. So why is that? Well, the reason for that is that the lung parenchyma, represented by these springs, the lung parenchyma, has a tethering effect on the airway, pulls out on the airway. So as you increase lung volume, the chest wall expands outward, and the tethering effect of the lung parenchyma on airways increases so that the airway size, radius, is greater at high lung volumes than at low lung volumes. So then, if we destroy alveoli, if we destroy the springs here, which are alveoli, with alveolar destruction, there is a loss of the tethering effect on the airway so that the airway can collapse. And that's what happens with COPD. So with emphysema and alveolar destruction, there is a loss of radial traction or tethering of the airway. So in patients with COPD, particularly with emphysematous COPD, there's a decrease in alveolar diameter and airways resistance increases. Now, another interesting aspect of the physiology of flow and resistance is that the flow out of the lungs is to a large extent determined by lung volume. So if you exhale normally to FRC and you blow out, you cannot generate as much flow as if you breathe in to total lung capacity and then blew out from a larger lung volume. So lung volume is a big determinant of how much expiratory flow you can generate. And that is primarily because elastic recoil pressure of the lungs is determined by lung volume. So if you breathe into total lung capacity, there's more elastic recoil pressure trying to cause the lungs to collapse. Also notice that when you exhale forcibly, the expiratory flow increases to a point at which the harder you blow out, the flow doesn't change. So here, at this lung volume, if you blow out with this amount of effort, the flow is at this level. And if you blow out at 5 times that much effort, the flow out of the lungs doesn't change. And the same here at mid-volume. So the flow of gas out of the lungs is determined not so much by how hard you push, but by what the lung volume is. What is the elastic recoil pressure? So why is that? So that is because of something called the equal pressure point, which has to do with the fact that airways are collapsible. And collapsible tubes are called Starling resistors. So airways act like a collapsible tube. They are supported by the airway parenchyma, but if they get less support, there's more pressure on the outside, they tend to collapse. So look at this cartoon, which I would say is crudely drawn, but I drew it and it's not too bad. So this represents the chest wall. So here's the chest wall. Here is the lung parenchyma, the alveoli. Here are the airways. And between the chest wall and the lungs is the pleural space. So let's imagine that you breathe in and you blow out, generating a pleural pressure of 30 centimeters of water. The important point here is that that 30 centimeters of water is applied not only to the alveolar space, pushing gas out of the lungs, that pleural pressure is also applied to the airway. So not only is there 30 centimeters of water pushing out on the alveolus, there's 30 centimeters of water collapsing in on the airway. The 5 here represents elastic recoil pressure. So that's the pressure that the lung parenchyma is generating by trying to collapse. So the alveolar pressure is the 5 due to elastic recoil plus the 30, that's your expiratory muscles pushing in. So we have 35 centimeters of water in the alveolus pushing gas out of the lungs. But this pressure decreases along the airway because of airways resistance. So the pressure is going 35, 34, 33, 32, 31, 30. And here is the equal pressure point where the pressure outside of the airway equals the pressure on the inside of the airway. And further downstream on the airway pressure will be less than the alveolar pressure or the pleural pressure, which will cause a collapsing effect on the airway. The reason why this airway doesn't just completely collapse is because normally in you and me, this point is in large airways, and large airways are supported by cartilage so that the airway does not collapse. But if you were ever assisting with bronch and the patient starts coughing, and you're looking down the bronchoscope in the trachea, what does the trachea do? The posterior segment of the trachea collapses because they're C-shaped rings of cartilage. But the trachea doesn't collapse completely unless the patient has tracheoblation. So the reason why when we take a deep breath and we blow out hard, we don't just all of a sudden can't get any more air out because the airway collapses is because the equal pressure point is in the part of the airway which is supported by cartilage. So now let's imagine that instead of blowing out with a pressure of 30, we blow it out with a pressure of 60. So now we contract our respiratory muscles harder and we increase the pleural pressure to 60. Let's say we have the same alveolar elastic recoil pressure of 5. Now the driving pressure is 65. But we have the same decrease in pressure along the airway due to airways resistance. And guess what happens? The equal pressure point occurs at exactly the same place. Which is the reason why, for a given lung volume, if you push out harder, you don't get any more gas flow out of the lungs. So then it doesn't help, in fact it may be counterproductive, to try to get more flow out of the lungs by squeezing on the chest wall, right? For patients having difficulty exhaling, it's not going to make any sense to try to squeeze on the chest wall to get more flow to come out. It's not going to make any sense to pile sandbags on the chest to get more flow to come out because of the equal pressure point. And in fact it becomes, for you and me, that's a curiosity of the physiology. It doesn't really affect our function. But in patients with disease, it can. So take the patient with asthma who now has bronchospasm. The result of the bronchospasm is that there will be a big pressure drop across the airway from before and after the point of obstruction. So rather than having the pressure dropping 35, 34, 33, 32, now the pressure goes 35, 34, 30, and now the equal pressure point is closer to the alveolus, more upstream, closer to the alveolus. The consequence of that will be, if the equal pressure point is in airways that are not supported by cartilage, then they will collapse. And they will collapse in the bottom of the lungs before the top of the lung because of pleural pressure gradient that we talked about before. And that results in the flow volume curve for a patient with asthma to look like this rather than normal. Or in the patient with emphysema, the problem is that you lose that tethering effect on the airway, as we pointed out before. So now instead of the elastic recoil pressure being 5, it is only 3 because there's a loss of alveoli, a loss of elastic recoil pressure, and also a loss of tethering on airways. So with the loss of elastic recoil pressure, we start out here at a pressure of 33 rather than 35. And again, the equal pressure point occurs further upstream in small airways that are not supported by cartilage. And hence, the flow volume curve in a patient with COPD often has this kind of shape. And what does this point represent?
Equal pressure.
The equal pressure point, which is occurring far upstream, close to the alveolus. So this represents the equal pressure point and airways collapsing. So when airways collapse, there will be no gas that will come out of the upstream alveoli, and hence the flow will drop off precipitously. So this again explains why in your patient with COPD, who has high airways resistance, who has air trapping as a result of this phenomenon, we may try to split the airway by using expiratory pressure or PEEP, but we don't try to squeeze on the chest wall to push more gas out. In fact, squeezing on the chest wall to push more gas out will be counterproductive. So if you were thinking about designing a chest vest device that would squeeze the chest wall in patients with COPD, you're wasting your time because it's counter to the physiology. Those of you, I'm sort of chuckling a little bit to myself because those of you who worked in Iraq, you have heard Bob Brown talk about this kind of stuff over and over, right? This is one of his favorite things to do.
Is he still up there talking about it?
He's retired.
Rarely.
I know he's around yet,
But
he's not,
sort of like I'm
but
around,
he's not doing,
so, yeah.
right, he's not doing, he's not on service up now.
Okay, now the concept of resistance and compliance can be brought together by something called the time constant. The time constant, by definition, is the product of resistance and compliance. And it turns out that it takes about 5 time constants to get gas either into the lungs or back out of the lungs. So we said that a normal resistance, or maybe we didn't say, so I'll say now, normal resistance is about 1 centimeter of water per liter per second. We did say that a normal respiratory system compliance is 0.1 liters per centimeter of water. So a normal time constant is about 1/10 of a second. So it only, for you or me, normally with normal respiratory mechanics, it only takes about a ½ second to get gas into the lungs or out of the lungs. But you can also see that if you were to reduce the compliance, so in a patient with low compliance, it takes less time to fill or empty. That's called a fast space. And in a patient with a high resistance, such as the patient with COPD, it'll take more time to fill or empty, which is called a slow space. So the gas distribution then within the lungs is determined by the regional differences in time constant or heterogeneity within the lungs. So the parts of the lungs that have a higher resistance will fill and empty slower, and patients that have a low compliance will fill and empty faster. And that's kind of what this figure is illustrating. We can also put this together into the concept of work of breathing. So work is determined by tidal volume and pressure. So if you breathe at a higher tidal volume, your work of breathing will be greater. If it takes more pressure to get gas into the lungs, your work of breathing will be greater. And pressure is determined primarily by resistance and compliance, as we had already discussed. So in a patient with stiff lungs, there will be a high work of breathing. In a patient with a high airways resistance, there will be a high work of breathing. It's also interesting to note that physiologically, the ideal respiratory rate, the ideal respiratory frequency, is determined by the work of breathing. And it's determined by whether the work is elastic work due to a high compliance, should be due to a low compliance, or it is a resistive work due to a high resistance. So for you and me, the work of breathing is the lowest at a respiratory rate of about 15 breaths per minute. You would think that we were designed to breathe at a rate of 15 breaths per minute, and essentially we were. And in fact, our work of breathing will go up a lot if we try to breathe at a lower rate, and it'll go up a little bit if we try to breathe at a higher rate. Notice that in a patient with a decreased respiratory system compliance, because of the relationship between elastic work and resistive work, now the lowest work of breathing is at a higher respiratory rate. So how would you expect that a patient with IPF would be breathing? Fast and shallow. That is where the work of breathing is the lowest. And trying to coach that patient with IPF to breathe slow and deep is going to be counterproductive, because it's going to be a higher work of breathing to breathe at a lower respiratory rate. Whereas patients with a high airways resistance, like patients with COPD, the work of breathing is lowest at a lower respiratory rate. So it is beneficial then to coach your patient with COPD to breathe slower. But in the patient with IPF and other causes of a low lung compliance, trying to tell them to breathe slower will be counterproductive. So that patient with a low compliance who you are trying to liberate from the ventilator, who's breathing 35 breaths per minute, that might be the best respiratory rate for that patient to breathe. Bob, you're shaking your head up and down and side to side, so I'm not sure if you're agreeing with me.
I'm in agreement, Dean.
Okay, so now let's try to translate some of this physiology to our mechanically ventilated patient. So in our patient, ventilated with constant flow, volume controlled ventilation, the airway pressure waveform should look similar to the one that I am illustrating on the slide. So the pressure goes from the level of peak up to the peak inspiratory pressure. There's initially a bump in pressure due to the resistance through the endotracheal tube. And if flow is set on the ventilator to be a constant flow, square wave of flow if you would, the increase in pressure should be a straight line throughout the breath. If we set the ventilator for a descending ramp of flow, it'll have downward curvature. And the peak inspiratory pressure that we record dutifully with our ventilator checks is determined by the compliance, the resistance, the tidal volume, the flow, and the peak. So it's a relatively non-specific measure. It's determined by lung function. It's also determined by how we set the ventilator. Now, as you know, we can apply an end inspiratory breath hold to measure the plateau pressure. And by measuring the plateau pressure, we can separate out the resistive and the elastic properties. So the difference between the peak pressure and the plateau pressure, as you know, is determined by airways resistance and flow. And in fact, if you know the peak pressure and the plateau pressure and the flow, you can calculate the resistance, as we'll talk about in a few minutes. The difference between the plateau pressure and peak is determined by compliance and tidal volume. And as you know, if we know the plateau pressure and peak and the tidal volume, we can calculate compliance. The plateau pressure represents the end inspiratory alveolar pressure. So the plateau pressure is the pressure that the lung parenchyma is seeing at end exhalation. And we can put all of this together in this relationship, which is called the equation of motion. We'll talk more about that in a minute. Now, the other thing we need to appreciate is when we measure lung mechanics off of the ventilator, is that many times our mechanically ventilated patients have very heterogeneous disease. The disease is not uniform throughout the lungs. And this is grossly illustrated by a patient who was up in the MICU. This might be 15 years ago now. This is a young woman, by young, around 40 years old, who had LAM, a form of emphysema. She had a unilateral transplant. And this, the left lung, is the transplanted lung, and the right lung is the native emphysematous lung due to her LAM. And don't ask me what LAM stands for, because it's about this lung. You can look it up yourself. look up, you can Google LAM and emphysema. It's a form of emphysema that occurs in women usually at a young age. So you can see here that the right lung is very emphysematous, very hyperinflated. And the left lung is either rejecting or there's pneumonia. So here we have a decrease in compliance, and here we have an increase in resistance and increased lung volume and so forth. My point is that when you measure PIP and plateau and so forth in this kind of a patient, I have no idea what it means. I can remember one of the very smart but very naive residents saying to me on this patient, well, if we put in a double lumen tube, wouldn't we be able to figure it out? And that's sort of the long run for a short slide. So the answer is yes, but we're not going to do that. Now, something that has found its way into literature, really just over the last 10 years, is the concept of the stress index and how we might use the stress index to help to inform how we set the ventilator. So let's imagine that we set the ventilator for a constant inspiratory flow, square wave, and that the patient is not actively interacting with the ventilator. So the patient's being passively ventilated. What should happen is that the lungs are being inflated at a constant flow. The rate of rise in pressure throughout most of the breath should be constant, linear, straight line. And that's normal, and that's a stress index of 1. The 1 is actually the slope of this line, which if it's a straight line, be a slope of 1. But now let's imagine that we inflate the lungs at a constant flow, and we see that there's downward curvature in the airway pressure waveform. This suggests that there is alveolar recruitment that is occurring as the lungs are being inflated. So as the lungs are being inflated, the pressure in the lungs is increasing, alveoli are popping open, the breath is going into bigger space, so the compliance is decreasing. Compliance is increasing. Compliance is getting better. So what might this suggest that we might want to do on the ventilator? To avoid this tidal recruitment, we may want to increase the PEEP so that we maintain recruitment during exhalation. Because this is a form of ventilator-induced lung injury. If there's recruitment during inhalation, there's de-recruitment during exhalation. And here the stress index is less than 1. In this example, inflating the lungs with a constant flow, and now we see upward concavity. So here there was downward concavity, here there's upward concavity in the airway pressure-time relationship. So here the compliance is getting better as the lungs are inflating. Here the compliance is getting worse as the lungs are inflating. So why would the lungs be getting stiffer as they're being inflated? Well, we're reaching the elastic limits of the respiratory system, so the compliance is getting worse. So this would suggest overdistension. So here we may want to decrease the tidal volume or the PEEP. Here we may want to increase the PEEP. Now, does this actually translate into the care of patients who you might take care of? Well, this is something some of you, like Ernie, know that the stress index is something that I was enthusiastic about. And here is a patient who came into the MICU probably 5 years ago on a PEEP of 8. The plateau pressure is 20. I'm not sure how well you can appreciate the downward concavity, suggesting here that the patient needs more PEEP. Stress index is 0.75, so less than 1. And I actually had software on this computer that would calculate the stress index. And we increased the PEEP from 8 to 18. And I think we can all agree that that's a nice straight line now, and you probably don't need the curve fitting to see that that's going to be close to 1. Here's another patient, also from about 5 years ago in the MICU. This was a patient who had been ventilated for more than a month at an outside hospital who had ARDS and now has very stiff, scarred lungs. And the patient comes to the MICU on a PEEP of 10. Plateau pressure is 35. The tidal volume, as I recall, was like 200, so very low tidal volume. I think you can appreciate the upward concavity in the airway pressure waveform. The stress index was way over 1. Just like this. And in fact, in her, we decreased the peak to 0. And when we dropped the peak from 10 to 0, look at how much the plateau pressure dropped. The stress index is much better, but still a little bit over 1. And we couldn't bring ourselves to leave a patient on the ventilator when the peak was 0. So Ernie remembers these kinds of conversations we would have, but we would put it on 2 or 3 or something like that. 0 might have been okay. And this just illustrates that we can eyeball some of this right off of the ventilator screen. Say, here's a patient, again, a patient up in the MICU a few years ago, was on a peak of 12. You can see here the pressure-time relationship. When the peak is increased to 15, there's upward concavity suggesting overdistension. Now if we put a straight line on that, see that there are a straight edge on that, we can see that's a straight line, and we can see here the overdistension. Some of you will remember Ernie particularly. We used to blow up the waveforms on the ventilator. Maybe you still do this. Take a card. Everybody will be trying to see if it's a straight line or not. Now, what if we, and it was fun physiology. So whether nobody's ever done a study to show that studying the ventilator on the stress index makes patient outcomes better. I could argue that either way. But certainly interesting physiology. So what if we use pressure-controlled ventilation rather than volume-controlled ventilation? So with pressure-controlled ventilation, we apply a constant pressure to the airway, as you know, and now the shape of the inspiratory flow waveform will be determined by resistance and compliance. So in this example, which was done on a lung model, you can see that on a fixed level of pressure control, as airway resistance increases, the flow decreases, and in fact, at a very high airways resistance, the flow looks like a square wave of flow. And in patients with severe airways resistance, such as with asthma or COPD, the flow is very low in pressure control. The flow looks like it's a constant flow rather than a descending flow. And also the area under this curve on pressure control is a tidal volume. So the area under the flow time curve is tidal volume. So you can see here the high airways resistance. The tidal volume will be very low unless we use a very high pressure. Then we look at the effect of compliance on the flow during pressure controlled ventilation. You can see that as the compliance decreases, the flow drops off more quickly. So with a stiff lung, like an ARDS, the flow drops off very rapidly with pressure controlled ventilation. Okay, so I think maybe as we're losing our audience that this might be a good place to stop, because it's going to take more than a minute to go through the equation of motion. So the next time we can pick up with a discussion on the equation of motion, and we'll drag out this mechanics talk into 3 lectures instead of 1 or 2.